I'm impressed with your ability to keep plants alive. You are better at that than I am.
Funny story. This is not my apartment.
Hello, Duncan. Good to see you. As you know, but others may not, I'm Dr. Nicholas Schwartz, an emergency physician, also trained in psychiatry. I did 2 residencies, life pathway, which I don't necessarily recommend to everybody.
It's obviously something we tackle every day in the emergency department, I think often without even knowing it. And when we started talking about this topic, I think I started by saying, I mean, everyone knows what capacity is. And then I sort of like stopped in my tracks and was like, do we actually all know what capacity is?
I think it probably actually is as simple as most people understand it to be, in the sense that, we just want to assess whether they understand the disease process in question, they understand the consequences of following your treatment guidelines versus some other medically reasonable plan, and that they've demonstrated to you their ability to reason and exercise good judgment are intact, and what they're giving you at that moment is consistent with the way they would have approached this question at any other point in their life. This represents their underlying values.
I actually think this leads into an interesting question. Can patients have the capacity for some decisions in their medical care and lack the capacity for other medical decisions?
To answer the specific question, yes, absolutely. Patients can have capacity for one decision and not another. There's this kind of concept of a sliding scale, that for the less important, the less consequential decisions, we're going to have kind of a lower threshold for insisting on each one of those criteria being fully met to the degree that we might for a much more medically important decision. One patient had necrotizing fasciitis, and they were refused. They said they didn't want surgery. To allow that patient to say, no, I don't want the surgery, I get it, that's not consistent with my values, like, you really have to have met each one of your criteria to a great degree of certainty. Whereas somebody who has pyelonephritis and says, I don't want an IV, I just want to take the oral antibiotics, and you might say, well, I'm not sure you really get it, but you're not going to like hold them down and like force them to take an IV, when actually they'll probably do okay. You can come up with some plan where they get a oral antibiotic with good absorption and get seen quickly.
Do you have any patients that come to mind when you think of, difficult cases that you've had to hash out before?
The difficult cases, broadly speaking, are the ones in which, up until that point, you've been having a reasonable conversation with the patient and is tracking along with you at each step in the decision-making process, and then suddenly kind of diverges from your perspective. For instance, I had a patient, an older guy, who was on Eliquis and fell, hit his head, lost consciousness, and he didn't want the CT scan. He just wanted to leave. He was reasonable in his decision making, in the sense that he could tell me why. He had been in a military hospital at one point, had a terrible experience there, and that had always been true. His wife was there with him. His wife wanted him to stay, but at the same time was able to validate that this is just how he is. To our earlier point, this is consistent with his core values as an individual. This is a difficult one because I knew that there was no danger to him of getting the scan, that I could get it quickly. I could shoot right over to radiology, tell them the situation, they would have him in and out. And it was, a high risk situation. It wasn't somebody who I could just shrug off and say, we always do this, but I bet this guy will be fine. I wasn't sure he would be. In the end, I had to say, he's got capacity. And I, gave him my cell phone number. I told him I'll be here all night. call me if you have any questions, if anything is wrong. I established that there was going to be a plan for follow-up. I took down their phone number so I could call him the next day. I did everything I could to try to make sure that he was going to be safe, but signed him out. When people first started talking about decision-making capacity in a more refined academic way and delineating what constitutes capacity, how do we decide? They were talking about patients who had an ongoing relationship with a physician in the medical office that could be discussed at some length. Transfer that to our situation, we've never seen the patient before. They've been in the emergency room for a while, are sort of frustrated, just want to leave. And these factors sort of undermine our ability to engage with them and do what we want to do, which is ideally to partner with them in helping them to make the best decision that they can for themselves, for their own medical care. We shouldn't see our role in this as convincing the patient to do what we want them to do. Our role is to sort of be their guide in arriving at a decision that's most consistent with both what's best for them and what resonates most with their internal values. A very simple example is, a Jehovah's Witness who doesn't want a transfusion. Our role isn't to sell them on the idea of transfusion. Our role is to help them arrive at a decision about their medical care that will be consistent with what is important to them, both for legal and ethical reasons.
Which patients should I say, you know what, this goes beyond what I'm able to do in the emergency department and I need to call for help?
Sometimes calling for help can just mean asking another emergency physician to take a look. You don't necessarily have to call psychiatry, but usually that's where you're going to turn. The situations in which I would recommend that an emergency physician, make that consult are for a psychiatric patient who sort of appears acutely decompensated. You're better off having psychiatry see them for a couple of reasons. Often, especially like a patient with a psychotic disorder, a schizophrenic, for instance, they'll have kind of idiosyncratic ways of communicating, their style of speech, but engagement maybe more generally, the way they project their affect. And it would be helpful to have somebody who's trained in interpreting that, because they're going to be able to better parse out what is psychopathology that's separate from their capacity versus what is impaired capacity. The patient kind of doesn't seem to appreciate the gravity of the situation. That may be because they're projecting negative symptoms of their schizophrenia and their affect is subdued just on the basis of disease, which one might misinterpret to mean this patient just doesn't get how serious this situation is. So that, that's a way in which a psychiatrist might be helpful. Sometimes patients, either because of psychosis or anxiety or depression, are just much more withdrawn and less willing to engage in a discussion. And part of psychiatric training is to understand how to get those patients to engage in and how to make them feel more comfortable if they're going to have a conversation that will give you the information that you need. Again, for a high stakes patient who is proposing to do something that you think is very dangerous, as Billy Mallon always says, don't carry the coffin alone. Like if you think things are going to go south, get other people on board that are going to be able to participate and support whatever outcome you as the emergency physician are ultimately signing off on. And then the last thing is time. These conversations, I think if they're done well, take a bit of time, and to give the amount of time to that conversation that it requires might mean that you're ignoring, 5 other critical patients that are in your department. Sometimes for sort of exigencies of our job, you have to make that call and have somebody else come and help you out.
This question always comes up. My patient is drunk, but they want to leave. If you're under the influence of something, do you automatically lack capacity at that point?
Yeah, it's a good question. Not automatically. I mean, the reason people drink, take drugs is to alter how they think and feel. And so that in itself then goes to our point of, is what we're seeing in front of us right now consistent with the person who might otherwise be out there, non-intoxicated? But nonetheless, if you talk to a patient, even in the midst of their intoxication, and you assess each of the criteria that we've discussed, and have reasonable confidence that they understand and are making a decision that's reasonable for them, then you can still say that the patient has capacity to make that decision. I would probably limit that to less medically consequential decisions. One's capacity is not a priori eliminated just by the presence of intoxication. How I do it, which is not to say this is going to be right for everybody, but I think everybody might take from what I'm saying some ideas on how they want to approach a situation like this. By the time we're having this discussion with the patient, they're often ready to go. Like that's usually why this comes up, because they're declining either an admission or a procedure. And that generally has occurred sort of toward after they've had the x-rays and the labs and the IV fluids and been sitting there for a while. With that in mind, I will try and be much more of a human being than a doctor when I approach them. I don't go up to them with a AMA form in hand and say, sir, I need to make sure that you can tell me you understand what's on this sheet. I'll kind of approach them and I'll in a sort of gentle manner with a soft smile if I can, hey, I heard you don't want to stay. What's on your mind? And let them kind of unload on me the frustration, the anxieties that they've got that went into their saying, no, I don't want to do this. No, I've had enough. And the phrase I've gotten most sort of mileage out of, I think just in my career in general, is just saying, yeah, I hear you. Because they haven't really, I think, often felt that they've been heard for much of the time they've been there. The 6 hours that they've spent in the department, of that, maybe 5-10 minutes has been with actual physician engagement. I'll often at some point kind of agree with them. Like I hate being in hospitals. I don't trust these doctors. Whatever they say, I'll sort of say, I know what you mean. I totally get what you're saying. The other thing that I think is really crucial is to have family involved. Family members do a number of things. They help to settle the patient because the patient will feel like even if I'm not their ally, that they've got an ally there. Family member can give you information about, like I said with the veteran who didn't want the head CT. They can tell you, yeah, this is always how he's been. And I'll tell you right now, doc, he's not going to change his mind. Even if a family member isn't there, I'll sometimes say, can you get a family member on the phone, or can I call? Can you give me a phone number for a family member that I can discuss this with?
Great. Nick, thank you so much.
I appreciate
it.
Of course. Happy to. Good to see you again.
Likewise.